Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
All right, the long anticipated question, Mike. What did you do the last week?
Ooh, a great question. So visited Durham, North Carolina over the weekend. Saw an old friend from college. A lot of fun. It was a great weekend. And prior to that, I've actually been, I guess listening. It's an audiobook, a series called Red Rising. It's a science fiction fantasy novel series. I'm in the second book. I'm fully invested. I've gotten a lot of chores done listening to it. So that's my week. It's been a great one.
Mike, as a federal employee, that sounds very non-productive. I don't know about this.
Yes.
I don't know about this. Is this what you're gonna? Are you reporting to your superiors, Mike?
I can't say. I can neither confirm nor deny. What about you? What did you do last week?
I did mixed teaching service and admitting, had some good cases. I'm just happy. It ended up being kind of like an 8-day stretch, which is slightly my usual. And one of the shifts was weird. It was like an evening shift, like 5 to 10 p.m. So I was all discombobulated, just happy to be off now and hanging out a little bit.
That's great. Well, I hope you sent your email in. For those, we'll post a few weeks from now. So for those who are listening, we're posting this on Tuesday, February 25th. Let you guys scroll back a few weeks in New York Times and you can figure out what's going on.
I guess we have to do weekly updates now, actually. Maybe this is true. How we start every episode.
It's true. We'll send it each week out. We'll make a newsletter.
There we go. We'll try and be more productive. Can't be a guarantee, but we'll certainly try.
We'll do our best. Speaking of productive, let's see what you got for us today.
Yeah, thanks for tackling another case, Mike. Listeners, we've been trying to alternate our case presentations, but just by virtue of us both having neuro cases back to back, I'm going to go ahead and present Mike another case today, and more Mike teaching. This is great. No comments, Mike.
I was going to say I'll do my best to continue to provide productive conversation.
Oh, you're going to deliver on this one. Okay, so this is aliquot number 1 for this one. Super short. It's a case of a woman in her 80s that I was called to cross cover for AFib with RVR. Basically, some of these patients who are admitted to my hospital, they'll move across the street once they get a bed, and the person who is covering them on the other campus can no longer cover because, it's a very long walk away if something happens. And I get a phone call as the admitter on the other campus saying, hey, can you see this person with RVR? So I guess just stopping there, what are some ways you tackle this pretty common cross-cover question?
Couldn't have picked a more common scenario. I think this was my first call overnight as an intern, actually, like a month into residency. So I guess my question for you would be: do you want me to start with sort of at the bedside management or more of a schema approach? Happy to do either.
Books wide open. Well, whatever comes to mind.
Sounds good. So briefly, I'll try to spend a little more time on like differential schema, but briefly in terms of management, like all arrhythmias, right? Kind of everything flows from whether or not this patient is stable or unstable. I think the caveat with AFib is that oftentimes, I'd say the majority of times, it's not the AFib that's causing the instability. And so, that's a caveat. I feel like as an intern, I felt, you have a patient who's septic and has AFib with RVR, and I'm like, okay, just shock them, So it's important to remember that oftentimes AFib, like I'll talk about in a second, is sort of secondary to something else that may be driving the arrhythmia, or you've got sort of AFib was the final straw. So they had a lot of things that were setting up hemodynamic instability, and then with AFib, rapid ventricular response, you decreased your diastolic filling time, less efficient contractions, and you finally sort of created a hypotensive state. So not that shock is the wrong answer, but I think it involves a little bit of consideration, because if they have a obvious trigger and you don't do anything about that trigger, then you're going to shock them or you're going to give mammo. The chance that they'll revert is high. And remember that in someone who's never had AFib before, or anticoagulation's been interrupted or non-adherent, right? This is, cardioversion is not a small undertaking, right? So sometimes it's about oftentimes about getting the rate under control in the moment and doing that in a way that hopefully doesn't impede hemodynamic stability. And then trying to figure out what the trigger is and go from there. So, which I'll talk about in 1 second. So the way I sort of think about this management-wise is, first confirm that it's AFib, right? So get an EKG, make sure it's an narrow complex, irregular rhythm. Remember that you can have aberrancy, and so you can get wide complex, which is tricky. And ultimately, I won't kind of go through that much, but just remember that, let's say for the sake of this conversation, it's going to be narrow. If they're stable, I think that, calcium channel blockers, beta blockers are a perfectly good first line. I prefer beta blockers just because a lot of the patients in the population I see are much, much older, and we're not sure what their EF will look like. And so, you can throw an ultrasound probe on and see whether or not it looks like they've got a really severely depressed EF. But when the heart's fast, my POCUS skills aren't quite good enough to feel confident that their EF is, okay. So I find that Metope is the better choice, and it should not have much blood pressure effect, right? So if someone's teetering, it can definitely cause this to happen. But I find that pushes of like IV low pressure, I find that is a good starting point. And it also kind of tells you, right, if you give someone just a little bit of IV low pressure and their pressures now drop more, that's like a much scarier situation than if they can sort of handle it. So I think that's kind of the stable AFib with RVR. And then, like I said, if you've got instability, knowing whether or not it's from the AFib or AFib is a symptom and you're seeing sort of AFib as one other problem as a result of their underlying trigger is an important consideration. Again, obviously, if you think that they're unstable from their AFib, that's generally patients where the rates are in, I would say, greater than 160, 170, right? If someone has a rate in the 140s, it's very unlikely that they are unstable from their AFib, unless they've got like severe mitral stenosis or, an extremely low EF. Oftentimes it's not the cause. If it's in the 200s, then yeah, you probably would shock that person every time. And then if the AFib is a symptom, then really trying to find the underlying cause. This is sometimes where you see amiodarone used in the intensive care unit, which I don't think is it's not a bad choice. And cardioversion should pretty much always revert them. That's the point. But amio has it's less efficacious for conversion, although it often does happen. But that risk of conversion when you're not worried, when you're not sure of what the atria looks like from a clot perspective, sometimes is a little bit lower risk. So that's sort of management. There's a lot more nuance to it than that, but I'll stop there in terms of management. I'll see if you have any other comments on that, and then I'll sort of go through my approach differential wise, or maybe I can wait till the next aliquot, whatever you'd prefer.
Yeah, I think it's actually perfect because I think you can go through the diagnosis as I give you more data. And I think, when you're getting called for the cross-cover question, as you've naturally gone to, I think the management does kind of, outweigh diagnostics. You're going to be doing both in sequence, but, listeners, in terms of, checking for hemodynamic instability, answering the question, shock or no shock, I think that's the exercise you have to run. And that's what Mike is basically showing there. And I really like the pearls on which kind of hemodynamic states and past medical history make rhythm control more important, like the mitral stenosis that you brought up. But let me give you some more information. So before you go to see the patient, naturally you do some quick chart review. So again, this is a 80-something-year-old woman, and she's been admitted less than 24 hours ago due to concerns about several weeks of worsening fatigue, low oral intake, and subjective fevers. And for her past medical history, she was actually fairly healthy. She only had hypertension and osteoporosis for chronic conditions. However, she had just several months prior been given a diagnosis of temporal arteritis and been treated with almost 2 months of prednisone at a dose of 40 milligrams. And she absolutely hated how the prednisone made her feel, is what the initial notes say. So she had slowly decreased the dose and had just stopped taking it altogether about a week prior to admission. And this patient is not from our area, so we had no notes to confirm how exactly she received the diagnosis of temporal arteritis, but it sounded like a clinical diagnosis because she doesn't recall receiving a biopsy. The ED vitals originally showed no fever, normal heart rate, and a saturation of 94% on room air. Orthostatic vitals were normal, and presenting EKG showed normal sinus rhythm and no signs of ischemia. Her labs showed a sodium of 128, a chloride of 92, otherwise normal BMP, normal LFTs, and all blood counts were within normal. They sent a respiratory viral panel that was negative. And then, due to concern for potential adrenal insufficiency with their prolonged pred use, an AM cortisol was ordered, but it's not yet available to you. Her admission chest x-ray was read as clear. And on the initial H&P note, she had clear lungs, and she had no peripheral edema or JVP elevation. So when I was called, she had a EKG confirmed AFib with RVR sustaining to the 130 to 140s for heart rate. And it just showed some secondary repolarization abnormality related to the tachycardia, no ischemia. Her blood pressures were still holding fine within the normal range. Her oxygen saturation was still 93 to 94% on room air. And when you walk in the room, your first impression is this is a woman who looks much younger than her stated age. The exam you get appears exactly the same from the admission note I just gave you. But you do notice, though, you think she has a very low-grade tachypnea, and it's even subclinical from her perspective because she says she doesn't feel short of breath resting in bed, but you're looking at her breathe, and it looks a little bit fast. So you take your own history, and she says that in addition to her subacute fatigue, she's been feeling more winded over the last few weeks when walking around. And her family at bedside says that this exertional dyspnea is actually much worse than she kind of reports to you. And they say she has a chronic dry cough dating back to more than a year ago, but they think that it's been more frequent, the cough, the last few weeks. For the cough, she was in Texas, briefly hospitalized, basically for like what sounds like empiric pneumonia treatment, according to the family. And she like allegedly gotten better, but her dry cough ultimately persisted, and she's kind of bounces back and forth between the Northeast and Texas area. So I'll stop there. That's kind of just to summarize the ED presentation and kind of what she looks like at the bedside, and just very basic workup. And just curious what your thoughts are.
Just going to ask two clarifying questions.
Yeah.
So in terms of history, so the temporal arteritis was about 2 months ago, high dose prednisone, sort of self-tapered her off. And then the pneumonia presentation in Texas?
Yeah, very unclear. The family just says, she had this worsening cough, and they thought when she came to the hospital, she had pneumonia, so she got some antibiotics. She wasn't hospitalized more than 2 days. They sent her home on oral antibiotics, and a very fuzzy history on that. That maybe happened 2 or 3 weeks ago. They can't really give you more details than that.
Interesting. Okay, so the pneumonia diagnosis actually came between the prednisone RX and now.
Exactly. Yeah, exactly.
Okay. So I think that for her, we're in sort of the stable AFib region now. And again, so now we really want to think about, we have time, what's causing this AFib, right? And I think that I'm drawn to sort of two things. One is this history that she's giving us, which certainly has a very wide differential, but is localizing, to me, it seems, to the pulmonary system, pulmonary artery and the lungs. So I think that that's something that I'll talk about in a second. Worth noting that you said she's mildly tachypnic. Her oxygen level is normal, but 93 to 94 is a little bit on the low normal side for someone without any what seems like past medical history of lung disease. Was she a smoker? Was that in the differential or in the past medical history?
Yeah, no major smoking history.
Okay. Okay, good. So, I'm sort of drawn to that. And then the other thing would just be she's 80 years old. She has hypertension. Does she just have some sort of underlying predisposition for a cardiac cause of AFib? Oftentimes uncontrolled or long-standing hypertension can cause atrial remodeling, excuse me. And, large atria just tend to develop atrial fibrillation even intrinsically without another sort of obvious trigger. So those are my thoughts. I think that the way I think about AFib broadly is cardiac versus non-cardiac causes. And it's a huge differential. And it's important to remember that there are patients where there is no trigger other than an accumulation of past medical history that ultimately kind of increases their risk each year of developing AFib. And then at some point, you're just seeing them when that AFib finally becomes clinically apparent. So that's an important consideration, right? This can just be a progressive disease that then eventually arrives at this diagnosis. But I'd say that's the diagnosis of exclusion. Cardiac-wise, I try to make buckets within that. So you have the atria, you have the ventricles, you have the valves and the conduction system. And then you have sort of the pressure, the afterload, as well as the preload. I sort of think about all those things as cardiac. So moving sort of from the IVC onward, right? So you can have hypovolemia and shock, right? Poor flow into the heart. Very common, right? Dehydration, sepsis, shock, and acute anemia from acute blood loss. You can have a central line or a right heart cath that's stuck there and irritating the right atria or the right ventricle, if you're in terms of a right heart cath, or a very very poorly placed central line. Pulmonary hypertension, right? You can create a lot of back pressure on the RV and then subsequently the RA, and that can cause arrhythmogenic foci. And then ischemia, of course, can cause issues in the atria as well as the ventricle, right? So particularly like a right dominant heart with RCA disease can cause atrial issues. Ventricles, right? So similarly, if you've got poor preload, then the ventricles are going to be less efficient. And MI also, right? Very, very common. We have to think about ischemia for multiple parts of the heart. Myocarditis, cardiomyopathy, these kind of things. Valve-wise, I mean, the classic are going to be your mitral valve diseases. So mitral stenosis, you just have an atria that's constantly pushing against a very high pressure mitral valve and causes dilatation and AFib, both either chronically and acutely. MR as well. And then, of course, the back pressure from aortic disease also. And generally, it tends to be that if you have like a, let's say an MI and then you rupture one of the papillary muscles, that's going to be a very kind of overwhelming acute pressure change and can cause AFib kind of pretty quickly and obviously. But it can happen on a more subacute chronic. And then conduction systems. So, this is where I put electrolytes. People will put them elsewhere into non-cardiac, but that's really what's causing the issues when you have electrolyte disturbances, is it's causing issues with, depolarization, repolarization. And so I think about the electrolytes there as well. So that's cardiac. And there's other things too, but that's, I think, the things I think about. Pulmonary, I think, is important for her. So the most common is going to be directly hypoxia causing AFib with RVR. So COPD exacerbation, heart failure exacerbation, pulmonary edema from other causes, pneumonia. In her, with her subjective fevers and maybe more of a subacute cough, this kind of diagnosis of pneumonia recently, and then immunosuppression from this prednisone for a period of time. I think I'm most worried about something intrapulmonary, and I think I'm most worried about something infectious. You can also have, lung diseases like sarcoid, lung cancer. These things can cause that as well through many different mechanisms, also systemic inflammation. And then you can have actual things that invade the atria, the pulmonary veins. Not as common, but those things are very rhythmogenic, right? Because you have something that's not cardiac tissue stuck where there is conduction tissue. Then you got metabolic causes. The classic one is thyroid disease that we think about. I also put uremia here, as well as toxins. So ethanol, cocaine, amphetamines, intoxications. And then lastly, I actually think about this as another category is adrenergic causes. So sepsis, fever, infection are going to be by far the most common. Systemic inflammation from things like malignancy, very common as well. Things that we do to patients, right? So vasopressors, dopamine and epinephrine classically. Cocaine and methamphetamines also sort of mix in here. And then withdrawal states, particularly alcohol withdrawal, is a very common trigger for AFib with RVR. So that's my approach. For her, I'm most worried about a pulmonary disease. And it sounds like her chest x-ray was normal a day ago. And so he's giving me air quotes here. So maybe not. But I'd scrutinize the chest x-ray and of course, and take a listen, see if there's anything else obvious on exam. But I'd probably at this point obtain a CT of the chest. And I'd be looking for both intrinsic pulmonary diseases as well as, and I think I forgot to actually mention this, looking for a pulmonary embolism as well. So I probably would do a contrasted study. Otherwise, send your basic workup, try to assess volume status to make sure she, from the poor PO, she isn't like markedly dehydrated and would benefit from some fluids.
Oh, I love it.
So that's where I'm going to stop there. Rambled for long enough.
I love it. It's super comprehensive. I think the takeaway for the listeners is so many things can cause AFib, but context is everything, and see where the story takes you. And you were really drawn to this idea of hypoxemia and frank hypoxia leading to irritated atrial myocytes, just given the fever and everything else you mentioned. So that's just like a beautiful demonstration, I think, of how to go through this problem. Very long list, but go where the patient is telling you. So let me tell you what happened next. An AM cortisol was sent by the admitting doctor, which came back at 11, which is technically below the cutoff of 18 that rules out adrenal insufficiency. But endo had actually been consulted on admission, and they think that while the cortisol 11 is technically indeterminate, the lack of hypotension and orthostasis is inconsistent with adrenal insufficiency. And they basically say, look for other reasons for her admission. And for other hormonal stuff, TSH was sent and unremarkable. So since we didn't see any evidence of decompensated heart failure on both the admitting and my exam and the clear chest x-ray, I actually did give her empiric IV fluid boluses to treat for any component of hypovolemia, as you've suggested, can drive RVR. Other than that, I was really most interested, like you, in her hypoxemia and low-grade tachypnea. And remember, listeners, a pulse ox of less than 94% should generally be treated as abnormal, because when patients are tachypnic, they generally have respiratory alkalosis, and the results in alkalemia will shift the oxygen dissociation curve to a point where a saturation greater than 94% is required to maintain an arterial PaO2 of 60. And 60 is a magic number because that's what your organs need to see to not be hypoxic. So for the assessment of both hypoxia and RVR, I ordered the CT chest with IV contrast, just as you suggested, and it did not show a PE, but it did show ground glass opacities, predominantly in the upper lobes of the lungs. And they also commented on incidental scattered upper lobe cystic air spaces, and there were no pleural effusions at all. After all that comes back, I feel better about rate controlling her, since she doesn't seem to be compensating for any hemodynamic reason, and seems her fib is related to frank hypoxia. So I basically made sure nursing turned up her supplemental oxygen, and I started her both on IV and oral metoprolol, and we subsequently achieved rate control. So before I bring it back to you, I'll just show you the images of the lungs. Let me see if I can figure this out. This is a representative slice, more on the upper side of things.
Okay. A lot of ground glass. More central. I'm not seeing anything. Here's this cystic thing you mentioned. Yeah, there's like cavities.
which just to skip ahead a bit, I ended up sending to a radiology friend from med school, and he's like, these are like pretty non-specific, but I just thought it was interesting for this case. We can get back to that, but yeah, basically nothing fancy on that scan. It just shows, as I already said, these upper lobe predominant ground glass opacities. So back to you, Mike, since this is a patient you're only cross covering, you sit down and basically think about everything you now have before you sign out for the night. And you're just wondering to yourself, what definitive treatments and tests can I order before I leave and sign this patient out to the night team? And this patient's going to go on to some other rounding service. So you're going to add them to your follow-up list and see kind of what happens in the coming days. I'll let you know what I ended up ordering before I left the shift and what ultimately ended up happening. But what are some final things you'd want to order for this patient?
Yeah, that's a great. We should put that CT on the website. It's a fun one. So, you now have cavitary lung lesions, which is a fun differential, and GGOs or ground glass opacities, which is very nonspecific and can be seen oftentimes associated with inflammation, infection. But I mean, you can see that also with extra volume. You're telling me that she doesn't have, it's not like any pulmonary edema, so I think it's more likely inflammatory and infectious. Her recent travel to Texas is certainly just raises the specter of endemic mycoses. She's been immunocompromised. I don't know if she was taking, I mean, it sounds like she was on prednisone for at least a month and a half and high dose. I don't know if she was on PJP prophylaxis, but that's obviously, on the differential. And
She was not on PJP prophylaxis.
yeah, so that's another thing that's just worrisome. And actually, with PJP, you often see this like borderline hypoxia. Sometimes none until you actually ambulate people. It kind of is, that's the classic presentation. We don't see it much anymore, right? But 30 years ago, when it was very common in the AIDS epidemic. She's probably someone where you have time to think about the diagnosis before you just empirically start some sort of antimicrobial. Because it doesn't sound like, while she's sick and in the hospital, it doesn't sound like she's someone where, as a night team, you need to put something on before you have this conversation with, I think, infectious disease. Because I don't want to muddy the diagnosis, and we have time. If she was was septic and you weren't able to rate control her, I think you would probably start broad spectrum antibiotics, or something like Vancomycin. Might need to add Bactrim since we're worried about PJP. In terms of diagnostics, if she's coughing anything up, I would send that off. This is actually someone where a procal might be helpful if it's truly negative. There are fungal markers that help support diagnoses like endemic mycoses and PJP. So a beta-D-glucan is helpful. Would be helpful for PJP. And I believe there's a urine antigen and serologies. I know that's true for histoplasmosis, and I believe for coccidio and blasto as well. I don't know that I would order them overnight without talking to infectious disease, but I think that would be part of my sign out, would be to consider these things, just because of that being in Texas and these lung findings. And you're also mentioning the upper lobes. So, it does. I mean, TB is always kind of a classic you can't forget about with cavitary lung lesions, particularly. I don't know if I would rush her to a TB isolation negative pressure room, but if you're asking for a bronch, maybe you're also asking for AFB if we get to that point. I think those are the things I would start with. I'm sure I missed many things, but I'm interested to hear what happens next.
I think the discussion is perfect because it highlights the challenges of management reasoning. There's no singular correct path forward here. I think the chest CT findings were ultimately non-specific. So I think you're playing this game like a game of poker and not chess. You're being smart by kind of covering all of the bases. You can do what I did and try and be very strategic about it. But ultimately, at the end of the day, what you saw in the chest CT is super non-specific. So I think how you approach that problem is actually a perfect demonstration of how you can approach this problem basically like so many different ways. And you do have time in a situation like this. She did look quite well. So let me tell you how things played out. So, as I felt there was some concern that this patient may have some sort of fungal infection. I was particularly worried about PJP because of the upper lobe predominant ground glass and in light of the months of high dose prednisone without apparent PJP prophylaxis, which I didn't give you all at the beginning. If you remember, I didn't even mention the PJP prophylaxis. I was wondering how many people were going to pick up on it, and you did. You did consider, was this patient on PJP prophy? She was not when we asked the family. So the medication I started was empiric treatment dose Bactrim. I sent a beta D glucan test that came back days later positive at 208 picograms per mil, the upper limit of normal being 60. And she had not received any IV Zosyn or other IV meds that would have led to a false positive test, because there are numerous reasons that the glucan can be a false positive with these IV formulation meds. So her new hospitalist actually did have ID come by, as you suggested, and they recommended broadening the workup with histo and coxy urine antigen testing given the Texas travel, and both of those ended up coming back negative. Palm was consulted for bronchoscopy up front, I think because of this diagnostic uncertainty you mentioned and how broad the differential was, but the patient and family, they were ambivalent about pursuing this given her advanced age. And by the time the family decided they actually were agreeable to a bronch, she'd already been on Bactrim for almost a week. And at that point, Palm just deferred the whole thing because they thought it was going to be low yields. And they were ultimately unable to get induced sputums for her. And how it played out, her oxygen saturations improved and she was discharged. And at an outpatient follow-up 2 weeks later, she continued to feel well and she was not hypoxemic. So there's a lot to extract from this case, so bear with me. I'm going to go through 4 major takeaways, and the first one is non-pulmonary adrenal insufficiency related stuff, just because we briefly had to touch on that, because that was a sticking point for this patient's admission, just given these kind of very vague systemic inflammatory symptoms and, a prednisone taper. So where does adrenal insufficiency related to steroid withdrawal fall in terms of primary, secondary, or tertiary AI? Recall that primary AI refers to dysfunction of the adrenal gland itself. Secondary refers to pituitary dysfunction, meaning ACTH deficiency. And tertiary refers to hypothalamic dysfunction, meaning corticotropin-releasing hormone deficiency. And since patients on chronic steroids have no need for their bodies to synthesize any of these things like CRH, ACTH, cortisol, AI related to steroid withdrawal ends up falling into the tertiary bucket, basically. So I did some reading on UpToDate about intentional. Whoops, I lost my script here. Give me one sec. This note is too long. So I did some reading on UpToDate about intentional steroid tapers and risk of adrenal insufficiency. And while they do mention that steroid duration, dose, and potency play into the risk of HPA axis suppression, it turns out the data is so murky on this that they don't even provide rough numbers to use as guidelines for kind of who you should be worried about. They basically say if you do have concern for adrenal insufficiency, you can do the standard ACTH stim test for diagnosis. Big caveat here. In early central AI, meaning either secondary or tertiary, the usual cutoff of cortisol greater than 18 is not necessarily a rule out, because you can have incomplete adrenal gland atrophy, and that leaves enough tissue to produce some cortisol greater than the 18 cutoff when your nurse is pushing ACTH. But when your nurse is not pushing ACTH, when they're outside the hospital, the gland atrophy is enough, so they still suffer the symptoms of adrenal insufficiency. So that's just a caveat with the testing there. But I think my takeaway from that reading is that the diagnosis of adrenal insufficiency in patients on chronic steroids, it really hinges on the clinical picture. You need to have features like fever, fatigue, orthostatic hypotension, nausea, vomiting, hypoglycemia, like the real syndrome of adrenal insufficiency. And in this case, the symptoms somewhat fit adrenal insufficiency. This is why it was considered in the H&P notes and why it was tested for, but the vitals told a different story, and you took us there. There was no hypotension. The center of gravity was inside the lungs, with frank hypoxia being the driver of RVR, rather than a hemodynamic collapse that you'd expect from adrenal insufficiency. So that's exactly how you navigate that problem space, is how Mike did it. So teaching point number 2, the sensitivity of chest x-ray for pneumonia. If this hasn't been drilled into the brains of our listeners yet, great. The sensitivity of chest x-ray for pneumonia is not impressive. One study put it at around 45%. So if your pretest probability for pneumonia or other parenchymal lung disease is high, a negative chest x-ray is not sufficient for pneumonia rule out, and you need a chest CT, just like we acquired in this case. teaching point number 3, how to make the diagnosis of PJP. So to make a definitive diagnosis, the gold standard hinges on acquisition of some sort of microbiologic test. And this is like induced sputum or BAL PCR, DFA, or silver stain. But it can be hard to get sputum or a bronch. And that's basically like what happened in this case, right? Like the family was even contemplating getting a bronch. So how can you make a presumptive diagnosis? It basically hinges on the combination of compatible chest imaging, and that is essentially diffuse upper greater than low ground glass opacities on chest CT with notably absent effusions. And as in this case, this may be subtle or completely absent on chest X-ray. And then you need to combine that with a supportive surrogate blood marker for PJP. And this is where the beta-D-glucan test really comes in, because that captures the circulating amount of the fungal cell wall of PJP. There's a great Nature paper we'll put on the website showing helpful data on mean glucan elevation in proven and probable PJP infections compared to non-PJP patients. They found that a glucan greater than 144 picograms per mil has a sensitivity of 90% and specificity of 86% for distinguishing control patients from either probable or proven PJP. The average glucan level for proven PJP in the study was quite high at about 1,200. And recall this patient had a glucan of just 208. So she perhaps had a really early infection or something. And then finally, you actually alluded to this. While PJP is, of course, a crucial bug to have on your DDX for HIV-infected patients, it's also important in your immunosuppressed non-HIV patients. And we talk about this all the time with, the need for PJP prophy in our patients on chronic steroids. But you have to consider other patients like on TNF-alpha inhibitors. And, I actually thought of this diagnosis and sent this work up and even put her on the empiric Bactrim up front. Despite this whole discussion, we had time to think about it, and certainly we did. But one of the last cases I had in residency, actually, on the generalist service was a case of missed PJP in terms of time to treatments. There was a patient we had with diffuse parenchymal lung disease. That was pretty much all ground glass. And she actually ended up getting bronched, and she got empiric routine cap treatment, not with Bactrim. And as you suggested, as PJP looks, her sats were like borderline, like 94, 96%. And, because she was like feeling about the same to better, she was discharged. And a couple days after discharge, her bronch actually came back positive for PJP and started Bactrim right away. Unfortunately, she, and this is a patient who was on a TNF-alpha inhibitor for RA. I forgot if I mentioned that already. She unfortunately got quite sick and went to an outside hospital shortly after starting the Bactrim, and she actually had a hypoxic arrest and passed away from the disease. And it turns out that the mortality of PJP in non-HIV patients is double the mortality of patients with HIV. And I don't know the reason behind it, but it's basically very important to catch for non-HIV infected patients. But that's the story of PJP. The forgotten infection, perhaps, in the post-AIDS epidemic. We don't talk too much about pneumonia culprits all the time, I feel like, because we often don't have to, because we put patients on empiric treatment and they get better. But this is a story of a case where it was a rather classic presentation, and we just don't see these come around too often. But yeah, Mike, what are your thoughts?
Yeah, that was a great review, and I learned many things myself there. So thank you for, if no one else, you educated me today. So I really appreciate that. I think that I only really have two other things to add, which are both short. So you already mentioned one, and I think I mentioned the other earlier. So beta-D-glucan, like the classic false positive is Zosyn. And that's a really big challenge, right? Because a lot of the patients where you're concerned about fungal infection, you're concerned because they are failing some other antibiotic treatment. And so these patients will, it can be hard to interpret. I don't know, I'm sure there is evidence, but I don't know it about how high that number may be with like a Zosyn false positive versus a true infection. I wonder if the number for infection, like the quantitative number is much, much higher than in a false positive state. I don't know the answer to that, but that would actually be, I guess I'll look that up after. And then the other thing is just remember that PJPs, it tends to have a more insidious subacute onset. And certainly patients can show up crashing, But usually there is some sort of symptomatology that preceded it. And I remember when I was on the Donaldson service, which is our infectious disease service on the Yale Internal Medicine program, I remember kind of classically being reminded that, we had a patient who did have eventually had a diagnosed PJP, and the only thing they really had was that they felt dyspneic, and everything was, quote, normal until we actually did an ambulatory stat, and then they dropped into the 80s, and that prompted the CT chest, and then the ultimate diagnosis. So, and that was a patient with I can't remember what they had. I don't believe they had AIDS. I think it was a solid organ transplant patient. So just remembering that it doesn't show up the way that your kind of acute bacterial pneumonia does, and just because they're more mild, we think about PJP as like the super severe diagnosis, right? Because it's what killed many, many people with AIDS, but it can be insidious.
And Mike, to answer your question, I forget if it was this case or another one where we ended up sending a glucan, and ID had actually commented. They generally do look at the quantitative level of the glucan. That average level I'd given you earlier of about 1,200. It seems that's when they really consider this diagnosis more so. But then, as you were saying earlier, this patient had no other reason to have the glucan elevation. So in that context, it was clinically important here, even though ID wasn't super enthused about it. But this patient did not have Zosyn, as you said, which is a very, very common scenario. So thank you for teaching us that, Mike. Yeah, you did great. Thanks for discussing, man.
We're only as good as as the presentation we're given. So I appreciate that. Was very that's a great presentation. I feel like you led me right there. So thank you.
Take it easy, everybody.
Have a nice week, everyone. Thanks for listening, as always. This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.